hospitals really trust these AI algorithms and the cloud and infrastructure with the sensitive patient data? Because a lot of people worry about PHI,
Yeah.
and it goes beyond the worries around simply breach or HIPAA violations. I think it goes down to what are we actually exposing um,
Yeah.
to these systems?
It's a great question. And it's one that I think we've solved in most other secure industries. So if you're in finance or you're in defense, you're not really even contemplating solutions that are shipping your sensitive corporate data or government data out to vendor clouds. So I think the better delineation than cloud versus on-prem is client versus vendor. Like, are these AI tools running within a client-controlled environment, so in a hospital's data center or a hospital's cloud? Or are they running within a vendor environment, right? The developer's cloud or the developer's data center? That's the more important distinction, because that distinction determines where patient data is. It could be in Azure or AWS, and if it's in the hospital's AWS, guess what? They don't care. Like, there's no additional risk versus if it's in their data center. I think the challenge with AI is that almost every single AI model on the market operates within the vendor's cloud or data center. It operates within the vendor's environment. And every single hospital system that you talk to vastly prefers that the AI run within their environment. So there's a fundamental disconnect in how hospitals want to buy technology. They want models that can be downloaded like an app on your iPhone into their data center or into their cloud, run within their firewall, adjacent to their information, and present no risk exposure. And vendors all want it to run in their cloud, and they want the data, and they want the access, and guess what? When they're given the access, they end up breaching it. They end up secretly using it to retrain their models. They end up with all these issues that arise. And like it or not, in healthcare, the solutions that succeed are going to be the ones that the hospitals decide to adopt, which means that hospitals are increasingly looking to platforms that can take those models that are currently in the model cloud and download and deploy them within the hospital's private environment, whether that's any one of the hyperscalers that the hospital is using, whether that's hospital's data center. I think that's a missing layer of compute, right? Like, who's going to own and manage the GPUs in that client environment? It's not going to be the vendors. It's not going to be the hospitals. And so that's the missing layer, is the actual AI application environment, that middleware layer that's actually connecting the AI to compute, connecting that to the patient data, connecting it to the interfaces that the doctors and clinicians are using, and supervising and governing all of that. Like, none of that is going to exist outside of the hospital's firewall, outside of their cloud or their data center, which means you need all of that middleware running in a hospital somehow. And that was one of the insights that we had when we started Ferrum was, wow, like, nobody's going to be able to do this. Hospitals sure as heck aren't. There are some great examples where they're starting to, Mayo Clinic, Mass General Brigham. There are some folks that are, but 99% of health systems are never going to be able to build the sort of orchestration and integration engines that need to exist to support these tools. And they're also never going to be comfortable sending data to the vendor's cloud. So there needs to be a middleware. That technical orchestration and governance is where we started. And then we actually expanded from there into clinical and business governance as these tools became more widely adopted.
I find you the problem. I've never thought about it that way. So that's a completely new way for me of thinking about it, of in the vendor's cloud versus in the hospital's cloud. Don't you run into issues, though, thinking about this now from the AI supplier's perspective, of the fact that your models are actually continuously changing? And I've run into this before, where healthcare providers or systems say, you can use our data and run compute on it, but you can't use our data to train your model. And you go, well, wait a minute, I'm doing AI. It's continuously, like, every time I use it, it trains. And in fact, the value that's provided is this continuous training and updating and all of the fuzziness that comes with that. But that's actually what ensures that we're performing correctly and that we're adapting this technology to. It's no different. I was thinking of agentic AI. It's no different than an employee, right? You might work in one hospital and they go work in the other hospital, but they bring all the experience that they have with them. So does that dialogue come up of the whole difference between in the firewall versus out of the firewall and the actual benefits of being there? Or is it truly just the security issue overwhelms the pros and cons of both approaches?
Take that same argument and try it on the Department of Defense, or try it on a financial services firm. It's dead in the water. Combine that with the fact that unless we dramatically change how the FDA governs clinical software. These AI models can't continuously improve. Every time you change a single model, but you've got to resubmit it to the FDA. And we can change that, but that requires an act of Congress that redefines what FDA does. And so that's not likely to happen in the coming years. So we're kind of stuck. We're kind of stuck with this world where we can only deploy AI if we meet the security requirements. Regulators don't actually permit many of these AI tools to improve. And so they're not going to be adopted unless you actually deploy in a way hospitals and regulators want you to. In the agentic world, there is a change, but you know what the biggest concern is that these hospitals have? Is that these model developers are going to use this, and suddenly all of a health system's coding and billing data is going to be de-identified, aggregated, and made available to Optum to now analyze the market and do more work on. So what does it mean to de-identify? What does it mean to aggregate? How do you actually ensure that a patient record, a social security number, a diagnosis of cancer is going to be de-identified in a way that doesn't harm the system? It's not possible. So I feel like, just like other secure industries, vendors have been trying to use this talk track since AI was invented, and it just has never worked, and it's not going to work. The last thought on this I'll mention is, while the only option was Anthropic and OpenAI and some of these massive foundation models that only sold via API, sure, you had other choices. But DeepSeek, Llama 3, you're seeing all of these new models that are essentially equivalently performant, that are open source, can be fine-tuned to your local population, can be run locally on your own compute, can power all of these agentic workflows without any risk to patient data, with full control over your data provenance, with no security. So if you talk about where the future of AI is going to go, even with agentic AI, guess what? Far greater benefits to being able to fine-tune an AI model on my own data than some abstract aggregate benefit of an AI model benefiting from all of the different stakeholders that are involved.
I think we're going to see more of this idea of multi-tenant secure architecture, right? Where it takes a certain amount of expertise, to your point around the middleware, to deploy software, right? And to essentially make it part of, you got to bring it into the firewall, but where's the firewall? You know, firewall used to be like a physical server, right? A firewall. What's firewall in the cloud? Well, it's the compartmentalization of the data and the security layers that sit around it. And so I think the big question becomes like, what goes in and out of these different firewall sections, and how do we manage it? It's interesting what you talk about with the FDA, because I do think the FDA really struggles with the idea of continually adaptive algorithms. You know, we had discussions with them, I did certainly years ago, and they just understood why that could be really important and valuable, but did not have a regulatory mechanism that would enable them to regulate something that, you know, didn't essentially have code branches along the way. Where, like, why would you do code branches? We're AI developers. We don't believe in that, right? Like, let's just keep adapting.